Hello, everyone, and welcome. I'm Dave Iverson, the Michael J. Fox Foundation's contributing editor and the moderator of today's webinar, where we're going to talk more about variation in Parkinson's disease and whether or not one treatment can fit all, or whether or not we have to develop a variety of treatment approaches depending on the variation of Parkinson's that you may happen to have. You can log in every third Thursday of the month at 12 Eastern, 11 Central, 10 Mountain, and 9 Pacific to hear a discussion and ask questions about a current important topic in Parkinson's disease research. We hope you'll continue to mark your calendars and join us throughout the year. And if you aren't able to join us live, you can always watch these webinars on demand whenever you so choose. You'll be able to also add in your questions during our discussion. As always today, we'll start taking those questions about in the second half of our conversation, but we encourage you to use that Q&A box that you see near the middle of your screen, and you can type in your questions there, send them to us, and we'll do our best in the second half of our webinar today to respond to as many of those as we can. We'll also make the slides available from today's webinar to download. You'll see a box called Resource List on the screen. And you can just click on that link, and the document will open up in a new browser window, and you'll be able to save or print the slides from there. So let's get started and talk more about what we're going to be covering on today's webinar. Some of the questions that we're going to be focusing on today will be, what do we mean by taking a more personalized medicine approach? How do we go about defining the differences in Parkinson's disease today? And going forward, will we be able to use genetics as a way to differentiate the disease and target specific treatments for treating Parkinson's? But as we know, we think most people with Parkinson's disease don't necessarily have a genetic marker that makes them more likely to get the disease. So how could we personalize things for people who don't have that sort of genetic question? And then lastly, we're going to talk more about how we're moving closer through additional research to getting closer to a more personalized approach in treating Parkinson's disease. Let's meet the panel that's joining us today. Joining us from Asheville, North Carolina is Patty Meese. Patty is someone who was diagnosed with Parkinson's disease in 2008. She's someone who does have a genetic mutation, the LRRK2 genetic mutation, which is the most common kind of genetic mutation that can lead to Parkinson's disease. And Patty will be talking some about her experience both with Parkinson's and also her particular interest in furthering genetic research. Joining us too is Dr. Nabila Dahabwala, who is an assistant professor of neurology at the University of Pennsylvania and is currently attending a neurology convention in Vancouver, British Columbia. And Brian Fisk joins us as well. Brian is the Senior Vice President of Research Programs at the Michael J. Fox Foundation and heavily involved in trying to learn more, develop more of this approach to Parkinson's disease. So welcome all. Thanks all very much for all of you participating in today's webinar. Let's begin, if we might, Brian Fisk, with a bit of a description of what we actually mean by personalized medicine. If we could take a more personalized approach to treating something like Parkinson's, what might that mean? And how perhaps has that been successful in other kinds of diseases?
Yeah. So when you think about personalized medicine, it's actually a fairly straightforward concept, and it's sort of surprising that it's not something we've been doing, from day one. But it's really just about tailoring the drug that you're giving someone more specifically to their particular disease. And so, classically, obviously, you can think about that more in the context of, do you have a cold, or do you have the flu, or do you have something else? And obviously you would, tailor the treatment you give to that person based on essentially their disease, what they have. But as technology and our understanding, I think, of the biology of disease has increased, it's really taken the concept of precision medicine to a whole new level, where we can really now not just target, the sort of symptoms that you might have, but actually hopefully target the actual underlying disease process, and therefore your drugs become much more precise, and that you can actually target the disease mechanism and try to slow or stop that process with a much more tailored treatment approach.
And it's something that's already, we've made some significant progress in other diseases, and it's sort of where we'd like to get Parkinson's to get to. And we see on the slide, Brian, two examples of that, one in cancer and one in cystic fibrosis. And I think it's helpful to get a concrete example to understand this approach better. So why don't you give us the cancer example, if you would, and then I'll ask Dr. Dahadwala to describe how this approach is working in cystic fibrosis.
Sure. Yeah. So cancer's really, I think, been in particular, really a pioneer and field leader in this idea of precision medicine. And that, in that case, as people have studied and understood really the underlying genetics and sort of the biology of cancers, and in particular the tumor cells that develop in cancer, they're able to think much more specifically about how to target those particular tumor cells with a particular drug. And a good example of that is actually a drug called Gleevec, which has been developed to treat a certain type of blood cancer called chronic myeloid leukemia. It's a really sort of devastating form of leukemia that is induced by a particular sort of genetic change where a particular gene sort of gets messed up. And so because they've been able to really target and understand that genetic difference, they've been able to develop this drug to really target essentially the functional effect of that gene change. And so that's allowed them to really specifically then develop the drug, in this case Gleevec, against the mechanism by which that gene change is causing, in this case, the tumor growth in that form of leukemia. So it's just a really good example where they've been able to marry the biology to the treatment.
And does that mean then, Brian, we see that bottom point that precision medicine is all about getting the right treatment to the right patient, that this is the right treatment for that particular form of leukemia, but would not be effective in someone else's leukemia, that this is really about not just a broad definition of a disease like leukemia, but sort of slicing it up and making sure we apply what's right to the particular version of leukemia that someone has.
Exactly. So, the idea is that we tend to classically, think of cancer by location. So it's skin cancer, it's blood cancer, it's brain cancer. But when you actually look at then the cells that are sort of overgrowing and forming tumors in those types of cancers, and you realize what's really causing those cells to sort of overgrow, it's because of a particular genetic change, you're able to be more precise in exactly how you target that with a drug. And so in this case, there are many forms of leukemias out there, but for people with this particular genetic change that is linking to their form of leukemia, this drug might be more beneficial, but someone who doesn't have that genetic change, it might not.
And Dr. Dahadwala, give us the similar story with cystic fibrosis, a disease that has long been, hasn't had effective treatment. How has this more personalized approach provided a breakthrough, at least in treating one form of cystic fibrosis?
Oh, sure. So just to review a little bit, cystic fibrosis, if people are unaware, is a genetic disorder that affects many different organs throughout the body, including the lungs, the pancreas, the liver, the kidneys. And usually the manifestations of that are that someone with cystic fibrosis might have frequent lung infections, poor growth. And up until recently, most of our treatment has relied on preventing infections related to treating with antibiotics or improving secretion removal due to the impairment in the lungs. But more recently, as we understand the underlying genetics of this disorder, we have developed drugs that target the specific genetic impairment. So as you may know, genes encode for proteins, and the proteins have different functions within the cell. And in cystic fibrosis, the genetic mutation impairs the protein that allows chloride, which is an ion in our body, to flow from one part of the body to another part. And there's over 1,000 mutations in this gene, but all of the mutations in some way impair the function of that protein, but in different ways. And so the new drug that's been developed works on one of those mechanisms of impairment in the protein. It helps improve the flow of chloride from one part of the body to the other. So it only works for those specific mutations that impairs that inside part of the protein, but it wouldn't work for people with a different mutation that might prevent the protein to get to the right part of the body, or which we call trafficking in the cell, or it might not work for people whose protein stops being encoded prematurely. So it only works for that percentage of people who have an impairment in the channel function of the protein. So it's really cool. Oh, yeah, go ahead.
No, that's fine. Please finish the thought.
Yeah. Oh, I mean, it's really exciting and cool for medicine that we can so specifically target our treatment based on the underlying cause of the disease. And we have for a long time had a belief that the underlying causes are slightly different amongst all people. They're not always identical. So it really personalizes the treatment, which is hence why we have personalized medicine as the phrase.
With that understanding then of where we like to go with Parkinson's disease, let's begin to then turn our conversation to Parkinson's and think some about kind of where we are now and being able to differentiate different patterns within Parkinson's, but more broadly, where we'd like to go. So on this slide, we can see the question sort of how do we differentiate Parkinson's disease today? And of course, we're still working towards being able to identify a biological marker that would help us make not only early diagnosis, but also perhaps help us in this quest to differentiate different types of Parkinson's. But we are doing some things now to try to get a better differentiation and treat people more appropriately. So let's just take an example of the first one, Dr. Dahadwala, and then I want to bring Patty Meese into the conversation as someone who is diagnosed with Parkinson's to talk more about her own experience at the time of diagnosis. But we see that first point, Dr. Dahadwala, about, well, one thing that can differentiate perhaps how we treat Parkinson's is the age at which you're diagnosed, age of onset. When someone comes into your clinic and you assess someone and make that diagnosis, how does age of onset play into what you're going to then prescribe as your treatment regimen?
So age plays an important role for a lot of different reasons. One big one is how they may experience side effects of the different medications. So younger patients tend to experience fewer side effects than older patients, and that may be just because they have fewer other comorbid diseases or fewer interactions because they're on fewer other medications. So that's one big thing. The other one is the thinking about long-term complications of therapy, such as dyskinesias or motor fluctuations, which are more likely to occur in younger patients with levodopa therapy. That's not to say that everyone's going to have a different course, and levodopa, I think, is an excellent drug, but you would think about that more in a younger patient rather than an older patient. And then again, the last thing I think with age of onset is thinking about what you're going to have in your toolbox to use over time. And I think sometimes we like to have more options when someone's a younger patient because we know they're going to be living for 20, 30, 40 years with the disease, and we may start with maybe milder drug to start because we want to have more options as we move forward. So those are some of the ways in which age of onset might change how we or make it different in how we approach treatment.
Thank you. And let's bring Patty Meese into our conversation now in terms of her own experience with diagnosis. And Patty, say something, if you would, about what happened to you at your time of diagnosis and perhaps what the treatment regimen was when you were initially diagnosed, or what you have learned in the time since about having to adapt in certain ways, what's worked better for you in your particular progression with Parkinson's.
Okay, thank you, Dave. Excuse me. Well, I was 56 when I was first diagnosed, and it's been sort of a roller coaster since then. I went into a deep depression, which a lot of people don't realize is a non-motor symptom of Parkinson's disease. So, of course, my symptoms worsened, but through medication and a term that I use, HOPE, healthy options for Parkinson's every day, alternative methods. And as I said, my medication, I've managed fairly well over the almost 8 years. But I still struggle a lot with tremors, and sometimes when I'm off, I can hardly stand. My legs are shake so bad. But I also deal with some stiffness and bradykinesia on occasion. But I work through those things as well.
And that leads us, I think, into this bottom part of the slide that Patty has brought up about the different kind of orientations and problems that people can have early on, and what that may mean in terms of the way in which people may be treated. Brian Fisk, Patty mentioned some of the non-motor issues that were key for her first, particularly some of the questions having to do with depression, which, as Patty rightly noted, is something that's very common in Parkinson's, not always understood. Say something more, Brian Fisk, about the research effort that's going into that direction in particular to make sure that we adapt appropriate treatments for people who may be struggling as much with the non-motor parts of the disease as they are with the more standardly understood motor parts of Parkinson's.
No, it's a really great point. It's interesting over sort of the history of Parkinson's how, it's always classically been defined as this motor problem, this movement problem. But when you really look at people with the disease, there's a whole host of these other symptoms, many of these, again, so-called non-motor symptoms that they suffer with as well. And many of these actually are more disabling in some cases than the actual motor parts of the disease. A lot of these, this appreciation of sort of these non-motor symptoms as being truly part of Parkinson's, I think has, really only been appreciated probably in the last, 15 years or so, as people really sort of link these to the disease. Usually, treatments for these have traditionally tended to be more treatments for those symptoms that are sort of commonly found in other diseases, rather than being PD-specific treatments. And so, doctors will tend to prescribe, antidepressants for if you're depressed and you have Parkinson's, or if you have, issues with constipation, for example, they'll sort of give you drugs that are used for constipation. But we're finding in the last few years in particular, research and then obviously drug makers are starting to really tailor these drugs more specifically to the PD version of these symptoms. And so there's been some examples of these over the last few years, where this has happened. In fact, there is a drug that was approved, I think it was maybe a couple of years ago, for something called orthostatic hypotension, so a form of low blood pressure that people with Parkinson's often deal with. And this drug called Northera is now approved specifically to help with some of those issues for Parkinson's disease, orthostatic hypotension. There's also another drug that's being developed by a company called Acadia that is currently sort of in discussion with the FDA about and waiting for the FDA's final decision. We think probably in the next few weeks. That is specifically for a form of psychosis that PD patients often suffer, or a percentage of PD patients might end up suffering. And so again, this is a drug that's being targeted specifically for a PD version of this. And so I think it's important then to see that there's this growing appreciation that these are not sort of unrelated symptoms that people with Parkinson's just happen to also have, that these might actually be underlying features of the disease, Parkinson's itself, and that we need to make sure that we have treatments for those. Now, obviously, and we'll get obviously into this in a moment, if we can come up with something that targets the underlying disease mechanism, it's possible many of these symptoms could hopefully be treated with one type of treatment rather than having to give you, 5 different drugs for every symptom. But, obviously that's sort of the future where we're headed.
And as Brian suggests, we'll get to some of those next stages of where we hope to go to sort of slice into the different variations of Parkinson's more precisely and come up with more specific treatment regimens accordingly. But I want to stay with this just one beat longer. Patty mentioned, Dr. Dadwala, that for her tremor is more of an issue. And we see this bullet point on the slide here, tremor dominant versus gait dominant. And Linda emailed in a question just a few minutes ago saying, well, what are the differences between tremor dominant versus gait dominant? Just briefly, if you would, Dr. Dadwala, describe what that tells us as far as symptoms being oriented more one way than the other, and what that might mean in terms of making sure you get the right treatment approach.
Sure. So just to be clear, generally we call tremor dominant disease when a person with Parkinson's has mostly a rest tremor as part of their illness, whereas the gait dominant variety, there's no tremor. So in about 25% of people with Parkinson's, they don't experience tremor, but they still are treated in the same way currently because we're not at the point where we can personalize treatment based on the type of Parkinson's you have. However, what we are learning is that these different clinical features of Parkinson's might portend a different prognosis. So people who have more tremor tend to live longer, have less disability, experience fewer falls than people with the gait dominant form. And actually, this is really timely because just at the meeting, there was a presentation from our group at the University of Pennsylvania comparing the genetics behind the tremor dominant versus gait dominant feature that we see in Parkinson's disease, and that there seems to be a difference in the the gene for alpha-synuclein between the two types, and that actually is followed through when you look at the pathology. So after people with Parkinson's pass away and you look at their brains, people who had a tremor dominant subtype of Parkinson's have different pathology related to this gene, the alpha-synuclein characterization in the brain compared to the gait dominant. So we're learning more and more that these clinical distinctions that we make actually are related to the underlying genetics and the pathology that we see.
Well, that provides a great segue, I think, to where we want to go next, and that's to look at genetics and how that may more refine the very things that Dr. Dahdwala was just describing. So, Brian Fisk, Dr. Fisk, I'm going to ask you to give us just a very brief understanding of the role that genetics plays in Parkinson's, and then we'll get into some of these specific, like LRRK2, and ask Patty to describe her own experience and her own decision to be tested for that mutation. But Brian Fisk, on the role that genetics is playing, because as Dr. Dahdwala was just suggesting, it may be more than just these specific mutations that we see on the screen that lead to some more prevalence of Parkinson's among a small subset of the Parkinson's population. It may be that there are genetic changes that are happening that tilt people towards tremor versus gait dominant. So there's a lot still to be learned here, I know, but tell us a little bit more, if you would, about the state of our knowledge and why we think it is so important to hone in on genetics.
Sure, yeah. So it's, again, when you look at the history of Parkinson's disease, for many, many years and really decades, no one really considered Parkinson's a genetic disease. And I think there were reports of Parkinson's in families and things like that, but most people tended to think it was probably something else, something maybe more environmental that was leading to it. It really wasn't actually until the late 90s that the first sort of real solid evidence of genetic mutations linked to Parkinson's came about, and actually that was in the gene, for alpha-synuclein. And actually, notice it's just missing from this slide, but we should probably add that in. That alpha-synuclein actually has genetic mutations in it as well that are linked to Parkinson's, and that was the first real significant sort of awakening, if you will, among the research community that, hey, Parkinson's might actually have genetic causes. Since that time, since the late 90s, we've uncovered a variety of different genetic changes in Parkinson's. Some of them are, I would say, fairly rare, but in the population. A few have become a little bit more sort of common. You mentioned already the one gene that Patty has, LRRK2, is a mutation that was found in about 2004 to be linked to Parkinson's. Some of these others, PARK2 or Parkin as it's called, tends to be a genetic change that's often found in younger onset forms of Parkinson's. GBA is another genetic change. It's actually linked to another disease called Gaucher disease, but they found that people they worked their way back. They found that people with Gaucher disease tended to have a high risk for Parkinson's as well, and then they started to work their way back and realize that changes in the GBA gene were also linked to Parkinson's. So since that, or late 90s, we've actually uncovered a fairly, sizable list of genetic changes, some of them more or less rare than others, that seem to be linked to Parkinson's. It's still maybe less than 10% of cases are we able to sort of link it to a specific genetic change, but it's telling us a lot at the end of the day about some of the potential causes for Parkinson's.
And does that mean, Brian, that there's still a lot of ground to uncover here, and that there may be some things that might not necessarily put you at greater risk for Parkinson's, but might even kind of, as Dr. Dadwala was suggesting, push you towards a particular form of Parkinson's, like the tremor dominant? It sounds like there's a lot more we have to learn here about the underlying role that genetic change and risk may play.
Yeah, no, exactly. So, when you kind of look at this, initial list of, of genes, a lot of these, again, are fairly rare, sort of mutations in our genes that, clearly are linked to causing Parkinson's, in a fairly substantial number of people who carry these mutations. There are a longer list of genetic changes that don't outright cause Parkinson's in any really great way, but can definitely increase your risk for getting Parkinson's. And so it's really just a spectrum when you think about sort of the high risk genetic changes versus sort of the somewhat lower risk, but still slightly increased over normal or risk types of gene changes. And I think what's interesting is that some of the genes that have mutations in them that clearly cause Parkinson's also have some of these sort of more subtle changes in them, like alpha-synuclein, for example, that we just talked about, where there are some genetic changes that are a bit more common across the population, meaning more people have them, that maybe slightly increases their risk for Parkinson's, but then over time, and maybe in combination with other factors, some of those people could then sort of end up getting Parkinson's. And so I think that's what we're sort of realizing, that 90% of everybody else who don't have one of these sort of really particularly powerful genetic changes, there might still be some underlying genetics there that can sort of tell us something new. And I think the study that what we just talked about actually sort of falls in that category. It's some subtle changes in the gene for alpha-synuclein that seem to alter the amount of alpha-synuclein that's being made in the brain, and that over time that might push someone into sort of one or the other type of Parkinson's disease.
Well, let's dig in a little bit more to one of these, and then we're going to talk about how this may lead to being able to have more precise, more personalized approaches to treating Parkinson's, both those with specific gene mutations as well as this broader group Brian Fisk was just describing. pettiness, you're someone who is carrying the LRRK2 mutation that, if you have that mutation, puts you at significantly higher risk for Parkinson's disease. Tell us something first about your decision to be tested for it, why you did that, and your belief in the importance in participating in genetic research.
Well, I first found out I had the LRRK2 gene through a study at the NIH, and I was a little stunned, as I was when I was first diagnosed, because I didn't know anything about it, and of course I wanted to learn more. So I enrolled in the PPMI study with the Michael J. Fox Foundation. And the more I learned, the more I felt like more research needed to be done. And so I turned to my family because I thought maybe this is a gift. Maybe my family and I could help move research forward. So I turned to them and discussed them to see if they'd be interested in also participating. And all four of my sisters and my daughter were all on board to do so. And so they've all been tested. They immediately wanted to help not just me, but all my friends and just research in general. Now, I want to add that not everybody is interested in doing those kinds of things. Not everybody wants to know. But with the PPMI study, genetics, they do have genetics counselors that help people along the way. But I just thought that was maybe my contribution. I just thought it was the right thing to do. So I continue with the PPMI study at Emory. And I do want people to know, too, that just because they carry the gene, one carries the gene or has the gene, does not mean that they'll have or develop Parkinson's. And so it just motivated me to do more and become more involved.
It's a really helpful orientation, and I really appreciate a number of the points that you made, including that last one, that just because you carry this particular mutation doesn't necessarily mean that you'll get Parkinson's. And that's an important thing to understand, I think, Dr. Dahadwala, that these various mutations that we're describing, most of them don't necessarily mean something. They simply put you at higher risk. And we're getting a number of questions from people about how they go about finding out more and whether, importantly, they should find out more. For example, we have a question here about from one individual that says, how do you find out if you have a genetic mutation? Someone else asks, Tom writes, is this something that all patients with Parkinson's should pursue? So how do you, as a clinician as well as a researcher, Dr. Dahadwala, how do you respond to that? If someone comes to you and says, should I get tested? What are the benefits of that? What are the risks? How do you counsel people, I guess, about the value of genetic testing?
That's a great question. I often defer to our genetic counselor for that, which we have at our clinic. They're specifically trained in the counseling, but I obviously will talk to my patients as well about their concerns. And usually I begin the conversation with, why are you asking? Like, what are your expectations about the genetic testing? What would you like to gain from this knowledge? And for some people, it's that they want to know why they have Parkinson's disease. And I think that it's a very fair reason, but there's a lot of implications about knowing if you do have a genetic cause for the rest of your family. And so it can be a personal decision, but often it helps to bring your family into the decision-making, talking to the genetic counselor before moving forward. In terms of treatment, it doesn't change currently how we treat people in the clinical setting. So we don't offer it routinely to our patients, and it's usually a research study test that for many of these different mutations in order to get the testing done. But for research, as Patty mentioned, I think it's a phenomenal thing to do. I think it really helps us understand the underlying etiology of Parkinson's disease or causes and how to target treatment to those specific causes. But that would generally is always done within the confines of a clinical study, such as the PPMI study that Patty is enrolled in.
We're going to talk more in a moment about getting closer to being able to treat someone such as Patty who carries that LRRK2 mutation, and whether or not we're getting closer to the point where someone like Patty could take a particular drug that would help her specifically, because that's a very exciting part of this process. But Patty, I want to go back to you just for a moment to the question that Dr. Dahadwala raised, which is that if you're going to get genetically testing, it's important to talk that through with your family members because it has implications for them as well. Sounds like you did that in your family in a very thoughtful way. Can you just say a little bit more about that for people who are wondering about whether or not they ought to proceed in that direction, kind of your own and your own family's thought processes, I guess, in how you came to that determination?
Well, I really wasn't sure how everyone would react, but I just thought that, my family and I are very close, and I just thought that I wanted to see how they felt, and knowing that I had it, I wanted them to know that as well. But we didn't have very many. We haven't had family members who've had Parkinson's, so I thought maybe this would be a way for us to do so. But everyone, when I sat down with them, they all chatted with me about it. We had a long discussion, and they just felt like they wanted to do it. They immediately said, yes, how can I help you? What can I do? Tell me how to do it. And so they immediately got on board and involved. And one sister does have the mutation. She also has the LRRK2 as well as the the GBA mutation. Mm-hmm. And my daughter also has the LRRK2. But my daughter really wanted to know whether she had it. And some people want to be empowered, and that's how she felt, that she'd feel empowered and be able to move forward. and not wonder. Now, she only has a 30% chance of getting Parkinson's or developing Parkinson's, but she was counseled. They were all counseled along the way, and that, I think, is what's important. But I just felt like it was the right thing to do, to sit down and talk with them to see if they were interested. And again, not everyone's like that, but we just wanted to help move research forward.
And thank you for doing that and for participating in those studies. As we often say in these webinars, it's the key thing that anyone with Parkinson's and their family members can do is to participate in research. And as Patty is, I think, also appropriately saying, we can all find a research trial to participate in. You know, it won't necessarily be something in genetics, but even if you decide not to follow that particular course, there are many, many other ways in which you can contribute to research. All right, let's dig into what this means and how we can develop some more specific treatments. And Brian Fisk, a great question has come in, which is that I think is central to this particular discussion, which is there a difference in treating genetically derived Parkinson's and non-genetically derived Parkinson's? In other words, even if we come up with a treatment for Patty Meese and anyone else with LRRK2, does that have value for others who have other forms of the disease?
So yeah, I mean, I think it's a great question, and I think one of the big sort of research questions that are happening right now is that as we sort of uncover these, genetic forms of Parkinson's, are they truly separate forms of the disease with a whole sort of set of different symptoms and different ways of treating people, or are they really just sort of different ways of getting to the same disease, and at the end of the day, everybody with Parkinson's has, generally the same underlying, sort of mechanisms leading to their symptoms, just maybe caused, by different ways. So right now, the way people would be treated if they have a genetic form of Parkinson's is really no different than how sort of standard Parkinson's is treated. They're all going to go on some form of dopamine replacement therapy at some point, things like that. There may be slight subtle differences in some of the non-motor symptoms that some of the genetic forms might have. Either they might have more of one kind or less of one kind, and so you could maybe tailor your treatments based on those symptoms again. But really, there's no specific drug, obviously, that is ready to target the underlying mechanism by which you might get to your Parkinson's. Now, the hope, of course, is that as we uncover the biology that is linked to these genetic forms, it may actually point us to common pathways that are underlying multiple forms of Parkinson's. And of course, that would be very exciting because then, you could argue that a drug that is being developed to, say, treat a LRRK2 form of Parkinson's disease might actually be beneficial in people who don't have that LRRK2 mutation, but the sort of biology that is being affected by the LRRK2 mutation may be the same biology that is underlying their Parkinson's.
Let's look at this next slide, because this is a way of getting at what Dr. Fisk is just describing. And that's this, that even if you don't have a genetically oriented form of Parkinson's, that as we learn more about these different pathways towards that circle at the bottom, Parkinson's disease, we may find that these, as we see on this graphic here, that some of these different causes intersect. So there might be the cause on the far left and the cause in the upper middle come together at a certain point. And if we can then interrupt that path, we'll figure out a way to stop Parkinson's disease. As you look at this graph, Dr. Dadwala, is that sort of where we need to go next, is sort of a deeper dive into the kind of molecular underpinnings of the disease so that we can find where some of these different causes and pathways come together and then try to stop that pathway?
Oh, yeah, I think definitely. I think there's different ways to approach it, and I think having these types of models help us develop a plan of attack on the research side, because you have to start off with some hypothesis of how this works. But we're still teasing this out. We're still at the stage of understanding the different pathways, the different causes, and once we can fill in the blanks on this model, then we can really identify the best treatments for each pathway. So I think this is really the way to go in terms of understanding how to treat Parkinson's the best that we can and ultimately come up with a way to prevent it and potentially stop it.
So Brian Fisk, in other words, if we follow what Dr. Dadwala was just saying, and if we fill in a couple of examples here on this graphic, if we were to take the LRRK2 mutation that Patty Meese carries, let's say, and place that on the far left of this graph, and then on the one above it, let's say it's exposure to pesticides or something like that may cause greater risk. It may be that they follow, in the end, a similar pathway. So that if we develop a drug that would fix the LRRK2 mutation, it might also fix another cause. And then if we add this next point here on the graph, you wind up then stopping the overall pathways as those pathways converge. I know I'm just sort of offering a kind of hypothetical example here, but is that kind of the direction that you see research going?
Exactly. So, again, one nice thing about studying genetics in diseases like Parkinson's is obviously not only are you uncovering specific genetic changes that can help you sort of identify people who might be at risk for disease, and certainly there's major value in that. But that genetic change that you find, really what it helps scientists do is it sort of puts a flag in the ground and says, you know what, that this particular gene, when altered, can lead to disease. As you start to study then the biology of kind of what cellular functions that gene plays a normal role in, that will also point you to a cellular pathway or cellular mechanism that when altered can lead to Parkinson's. And you may find that there are multiple ways that cellular mechanism can be altered, whether it's specifically through genetic change like a mutation in LRRK2 or exposure to a pesticide or some other genetic factor, some other factor that might be altering that pathway. And all of those could end up converging on that same ultimate cellular function and then ultimately leading to Parkinson's. Or it may be the case, and this is certainly can happen as well, where there might be multiple pathways that can still get you to Parkinson's disease, and each of those pathways has maybe multiple triggers. I often like to think about, say you're a car mechanic and you have a garage full of cars that won't start, and you have some general assumptions about what might be causing that. You don't know for sure. For example, that you can jumpstart all the cars and that will get them running again for a period of time. But once you turn the ignition off, they go back to their same problem and you have to jumpstart them again. But if you really want to sort of fix the cars, you have to really look under the hood and decide, okay, what is really the problem here? And you may find that in 5 of the cars, well, it looks like the battery is actually dead. What I really just need to do is change the battery. And another few, it turns out that the battery's fine, but it's the spark plugs. I need to replace the spark plugs. And so I think you can kind of use that analogy to disease and really think about, at the end of the day, Parkinson's, or in this case, the car not starting, as your sort of final ultimate thing. But there may be multiple reasons for why that is happening.
Mm-hmm. Some people, Dr. Dadwala, are asking, since we've referenced environmental exposure, which has long had some association with Parkinson's disease, pesticides in particular, and some people are wondering if we've learned anything further about whether or not there are other examples of environmental causes that may, as Brian is suggesting, intersect perhaps with a genetic underpinning that leads you down the path towards Parkinson's. Have we learned anything more concretely about environmental hazards and risks that make people more prone to getting a Parkinson's diagnosis?
Yeah, I think this is a really fascinating line of thinking about how Parkinson's disease develops and thinking about the interaction between your environment and your underlying genetics. So as we've mentioned with LRRK2, not everyone who has this mutation will develop Parkinson's disease. Something like 15 to 30% of people will. So why do those people develop it and not other people? And I think many people hypothesize that it might be because of other genes that they have, or it could be something that they've experienced in the environment. And I think a really good example of this that I've seen in the literature is that another environmental risk factor that has been linked to developing Parkinson's disease is head trauma. But many people hit their head over time, and it's not very specific to, whereas pesticides are a little bit more specific of a cause. However, people who have had head trauma and also have a gene mutation, again in alpha-synuclein, are at even higher risk for developing a specific mutation in alpha-synuclein, are even higher risk for developing Parkinson's disease than people who only have head trauma or only have the alpha-synuclein mutation. So there's some synergy between the genetic mutations that you have and the environment and the exposures that you have throughout your life. And those are really complicated analyses to do, and we need lots of people in order to make those, to understand those associations, but they're starting to come out more and more as we develop these large cohorts of research subjects to study.
Well, let's look at how close we're getting in some of these areas to developing more personalized approaches, and talk more then also about how some of these may intersect. So as we've already been talking about, we're working on learning more about this interaction with the environment and identifying more ways that make people at greater risk for Parkinson's. And better ways of monitoring disease progression by identifying biomarkers. A couple of people have written in of asking about blood tests, for example, Brian Fisk. So let's just spend a moment and then we'll get to some of the genetic treatments that are being developed, because this is central to this too. If we had a way of kind of measuring what was going on both with diagnosis and disease progression, but also whether or not these treatments are working, like a blood test or a change in something in the cerebral spinal fluid or something else, it would allow us also to know whether or not some of these treatments. So are we getting closer? Some news just in the last few days about perhaps the potential for a blood test for Parkinson's. Where are we with that?
Yeah, so I think it's, it's been sort of slow moving over the years, but I feel like there's a lot of data now starting to come out, and, including, it was mentioned earlier about the PPMI study that the foundation is supporting, and how that's sort of looking for these types of biomarkers. And, I think we're definitely then uncovering, real changes that we think we can measure in people with Parkinson's that might be helping us to sort of distinguish, between different groups. And, a good example is we do know from our PPMI study that measures of the protein alpha-synuclein in spinal fluid of people with Parkinson's, at least a subset of people with Parkinson's disease, we find that those levels are reduced in their spinal fluid. And we don't know exactly why or the mechanism for that, but it seems to be a fairly consistent finding that, again, the subset of these people have a reduced level of alpha-synuclein. So, as we continue then to really, again, explore, a variety of different, fluids and samples from people with Parkinson's, we're looking for these types of changes that we can see, and that hopefully can help us sort of tease apart, whether someone has a particular, maybe subform, if you will, of Parkinson's or not. There's another classic example where a researcher up in Boston, Michael Schwarzschild, measured in a sample of people their blood levels of urate. And urate's just a common factor that was in all of our blood that has to do with sort of a natural antioxidant in our blood. He found that people with relatively higher levels of urate seem to have a slower progression of Parkinson's disease. So again, the idea is, could you use markers like this to sort of really identify and predict those people who have different forms or different progression rates or sort of different features of Parkinson's?
Mm-hmm. So in that case, Brian, by boosting uric acid levels, urate levels in a particular subset of people perhaps, that might serve a kind of preventative or disease-slowing opportunity. But it might not be something, it might not be where you'd say everybody with Parkinson's should have higher urate levels, right? I mean, it would be a more slice and diced kind of approach?
Possibly, yeah. There's actually some clinical studies now, in fact, a large phase 3 trial that's underway now to specifically look at a drug called inosine to raise blood urate levels in people with certain levels of urate in their blood to see if they can get them up to levels that would be hypothetically at least more protective. And so that study's ongoing. But that would be the idea, is that, whether raising urate levels would help everybody with Parkinson's, I think is unclear, but at least maybe those who have relatively lower levels of urate in their blood, it might be a way to hopefully slow their specific disease process down.
And Dr. Dadwala, the other part of this, you mentioned head trauma before may have a connection. Maybe you may be more likely to get Parkinson's if you've had trauma, if you have a particular genetic underpinning. Again, is that the idea is that we'll then get closer to being able to say, so if someone comes into your office who's had head trauma and has Parkinson's, that your approach right now isn't going to be different than someone who, had Parkinson's perhaps for another reason. But in time, you want to be able to match up head trauma combined with this genetic underpinning, combined with this environmental exposure will lead you to treatment X rather than treatment Y. That's basically the overall hope. Is that right?
Yeah, I think regardless of the underlying cause, whether it's genetic, environmental, or both, understanding the pathway that follows that is where and the cause is where, like, obviously we can prevent head trauma or change the gene expression that can help prevent Parkinson's disease. That would be great, except that generally those are harder to accomplish. So like with the cystic fibrosis example, the medication isn't changing the expression of the gene, it's changing what happens down that pathway towards cystic fibrosis. And I think that's where understanding those different pathways of inflammation, toxicity, neurotoxicity in the brain, calcium channel imbalance will help us target the treatment.
Brian, just say something at this point about where we are with developing some of these specific treatments in the genetic arena in particular. So we've already talked some, and Patty has described her own participation in genetic studies with those who have the LRRK2 mutation. How close are we to finding a way to fix that genetic mutation, to stop whatever goes wrong, or rather to alter that genetic mutation so that something won't provoke a Parkinson's disease experience? Where are we in developing those specific treatments?
Yeah, so right now, in particular with the changes in the LRRK2 gene, LRRK2, so a lot of companies currently are developing what are so-called LRRK2 inhibitors, and so these are drugs that would sort of target the LRRK2 protein. Again, genes are sort of instruction manuals for making proteins in cells, and so in this case, you have the mutation in LRRK2, which is the recipe for the protein LRRK2. Anyway, but the drug companies are making drugs that can target and inhibit the function of that LRRK2 protein because, based on the biology of what we know today, we think the genetic change is actually creating an overactive LRRK2 protein. And so that's sort of the rationale that drug makers have for making a drug that can inhibit that activity. So multiple companies are making these types of drugs now. It's actually not a particularly difficult drug to make. It's the type of protein that LRRK2 is actually a type of protein that drug makers have been making drugs against in the cancer field for many years, so they kind of know the chemistry of how to make these types of drugs. So right now, those companies are really doing a lot of the sort of later stage, safety testing and things like that to make sure that these drugs are appropriate to eventually move into human testing. Our sense is probably in the next, couple of years, we might actually see some of the first trials started with these drugs, which is for us obviously very exciting. Then we'll have to see really at the end of the day whether these are ultimately safe and effective in people. But it's definitely, getting very close. You didn't mention it, but another gene sort of change that actually is in the clinic right now are actually drugs against the protein alpha-synuclein, which we've talked about already a little bit on this call. Again, there are genetic forms of Parkinson's that are due to mutations in the alpha-synuclein gene. Also, too, everybody with Parkinson's actually has clumped alpha-synuclein in their brain, so there's a broader compelling reason for why we would develop alpha-synuclein-based drugs. But these are drugs that are now actually being tested in the clinic today. There's about 4 companies that have entered the clinical testing phases with drugs against alpha-synuclein. So yet again, another sort of biological form a sort of target that we know may underlie Parkinson's is now being targeted by drugs as well.
And just to underline the last point that you made, Brian, when you say in the clinic, it means in clinical testing, in clinical trials.
Oh, sorry,
it's not something that's
so,
available in the clinic.
Right, not approved yet for patient use, but in early sort of safety testing, making sure that it's appropriate, ultimately looking for benefits in people with Parkinson's, and then the data would be used to go to the regulatory officials to get approval to give to patients.
But incredibly exciting that perhaps within a few years with something like the LRRK2 mutation that pettiness carries, that there may be a drug available that can be tested and that could potentially fix that particular problem, which for you, pettiness, must be incredibly exciting to hear and motivating, I would think, as well to continue to participate in research.
Yes, absolutely. I have chills just hearing Brian talk about it, and I'm already thinking now, how can I get involved in that? Because I always, as a motivational speaker, I'm always talking to people about and often quoted as saying research is paramount in finding a cure. So I'm excited about that, and as I said, just anxious to learn more, and can't wait to find out what happens next.
A couple of more questions we want to get to before the end of our hour. Nancy writes in, can a patient who is unaware of any family member having a PD still have a genetic mutation? So it's an interesting question, Dr. Dadwala. So person wondering if I don't have anybody in my family that I know of, but might I still have a genetic mutation that put me at risk for Parkinson's or led to my being diagnosed with Parkinson's? Dr. Dadwala?
Yeah, no, that's a good question, and I don't know if I know the exact answer. It's definitely possible. It's probably less likely, though. So a lot of our genetic studies try and enrich our samples by only examining people who have a relative with Parkinson's disease. But given that we know that even if you have a mutation, you might not express the disease, I think it's very likely that you could still have a genetic form of Parkinson's without a family member having Parkinson's disease. But the chances are much higher if you do have a family member with Parkinson's disease. So I don't have like exact numbers. Yeah.
Right. But it does sound like what we're all saying is that it might be that you have something that kind of tilts you a little bit in that direction, and then it was perhaps the intersection with some other causal agent, be that head trauma, pesticides, or something else that tipped you over. So
exactly.
I think it sounds like we're going to learn more and more about how those intersections play out. Here's a question from Phil, Brian Fisk, that maybe you can answer, which is Phil wants to know what the fix would actually do. So Phil writes, if you find a genetic mutation, let's say like Patty's situation with the LRRK2 mutation, what's actually done to fix the problem?
Right, yeah. So, I mean, usually what happens is you've identified the mutation in a particular gene that's clearly linked to, a particular disease, in this case Parkinson's. Usually what you try to do next is understand what the protein that gene is, telling the cell to make, what that protein does in the cell and how that mutation might cause the protein to function differently. So again, for LRRK2, it's a classic example. We know the protein LRRK2 is a type of enzyme that goes around the cell and sort of chemically modifies other proteins in the cell to get them to do certain work that the cell needs done. And what the mutation seems to do is increase that activity. And so the theory is that increased LRRK2 activity is probably going around and maybe hitting other proteins that it shouldn't be hitting, or sort of activating, chemically modifying other proteins that it shouldn't be modifying. So the idea is that the drug then would go in, reduce that activity of the LRRK2 protein, and try to bring it back to more normal levels so that it's functioning normally. Now, sometimes when people think of fixing genetic changes, they're thinking of actually fixing the actual DNA change, and that's actually, it's probably important to kind of distinguish between those two types of treatments. The idea that you could go in and sort of actually fix someone's DNA and sort of make it go back to normal is I think something that's still very much not something current technology can really easily allow us to do. So it's unlikely that, at least for a complex disease like Parkinson's, that we're going to be able to go in and sort of fix your DNA. But what we can do is use the genetic understanding and then the understanding of the biology, the actual protein that that gene makes, to try to fix the function of the protein itself. And that's kind of what the approach is for gene changes like LRRK2.
One last question for you, Dr. Dadwala, and then I want to ask Patty to close us out with some further thoughts about the importance of participating in research. But a last question from Shilan, who asks, are different parts of the brain affected when you have different types of Parkinson's disease? So do we know yet whether or not these different pathways that we've been describing, be that genetic or environmental or any number of other things that may contribute to getting Parkinson's, do they change different parts of the brain, or do they all sort of converge with the same problem of that clumping alpha-synuclein in the brain?
So that's a good question. So it's not there. The reason that we see the kind of hallmark features of Parkinson's disease, the slow movement, the tremor in some people, the stiffness or rigidity, is usually because a specific part of the brain is damaged called the substantia nigra, and that is what gives everyone with the diagnosis of Parkinson's disease that's what groups them all together. But if once we start breaking down the causes of Parkinson's disease into different genetic causes and different environmental causes, we're starting to see that there probably are different parts of the brain involved in different levels. So you still may have disease in the substantia nigra, but it may be less than someone with like a gait predominant type of Parkinson's disease. And then in terms of like the non-motor symptoms, which now again in the past like 10 or 15 years we're incorporating more into our understanding of Parkinson's disease, the parts of the brain that control those features might be differentially affected depending on the underlying cause of your Parkinson's disease. So at some level, there is certain parts of the brain that are involved, that the same part of the brain is involved across everyone, because that's what gives us the Parkinson's disease diagnosis. But they're overlapping, and not always all the same parts are affected.
Thank you. Unfortunately, we're at the end of our hour, and we need to wrap things up. But we don't want to end the hour without, again, making a request that people really do consider participating in clinical research. And we have some information about on the screen about how you can find out about clinical research trials that are ongoing near you by using the Fox Trial Finder website. But Patty, if you would, just once you take the last word here and say something further about your own belief and the importance of people participating in Parkinson's research.
Well, thank you. I really believe that it's, as I said, paramount in finding a cure. I've been in over 25 studies, and people do not have to be in an invasive study. There are so many. I've been in a dance study. I've been in computer studies for brain improvement and things like that. So that's really important, and they can find them, as you said, on Fox Trial Finder. But I just believe it's a great way to help ourselves and other people live better lives, so that researchers can find better treatments for us and hopefully to find the ultimate cure for all of us.
Patty Meese, thank you. Thanks for participating in our webinar today.
Thank
Thanks
you.
also to Dr. Nabila Dadwala and to Dr. Brian Fisk at the Michael J. Fox Foundation for their participation as well. Really appreciate it. And thanks to all of you as well for participating in our webinar today. We'll be sending a link to the webinar on demand so that you can listen again or share it with others. There'll also be a survey link in that email that you'll be receiving, and we hope you'll give us your thoughts on today's presentation. And last, we just want to encourage you to mark your calendar for our next third Thursday webinar, which will be on May the 19th. And in that, we're going to be talking about the problem of psychosis in later stage, often Parkinson's disease, the problems that can develop sometimes with hallucinations and delusions, but as importantly, some really important new treatment options that Brian Fisk actually referred to earlier in today's webinar. So we're going to take that up in more detail in our next third Thursday webinar on May the 19th. We hope you will join us then. So until then, I'm Dave Iverson. Thank you for joining us.